So, well, this is a debate on why I should choose Abemaciclib as an adjuvant CDK4/6 inhibitor in early breast cancer. So, we have two drugs approved right now, Abema and Ribo, and I'm debating for why should I choose Abemaciclib. Right? These are my disclaimers. Well, if you look into the mechanism of action of CDK4/6 inhibitors, we have three. Among them, Abemaciclib is the only CDK4/6 inhibitor with a continuous dosing. Why continuous dosing matters is this. This is a study where upon discontinuing a CDK4/6 inhibitor, what happens to the Ki67? There is a rebound of Ki67 if I am not giving this for more than 4 days. Therefore, continuous dosing matters if you want to have a sustained suppression of Ki67. Right. So the famous line that we all know is cancer does not take a day off. Why a CDK4/6 inhibitor should take? We give 3 weeks on, 1 week off dose for palbo-ribo because of a marrow suppressing side effect, because of CDK6 inhibition also. However, because of preferential CDK4 activity by Abema, it has a marrow sparing effect. Therefore, we can give Abemaciclib as a continuous dosing, and continuous dosing is very important in terms of continuous suppression of Ki67. And you can see here, there is a rebound if I am stopping it for more than 4 days. Then what matters in the adjuvant setting? In a metastatic setting, it's okay, you take the cells for some growth arrest, a cytostatic effect is okay. Whereas if you look into adjuvant setting, we are actually treating micrometastatic disease. So here we need what is known as apoptosis of the cells. So if you look into the three drugs, Abema, Palbo, and Ribo, the growth arrest is seen. You know, if you see the three bars you have, the gray bar is the control one. If I am just giving DMSO, whereas if I give the equal molar concentrations of Abema, Palbo, and Ribo, the growth arrest is seen well with all the three. Whereas the senescence and apoptosis is more prominent. You can see the top most row, and you can see the amount of aging cells, senescent cells, and the apoptosis cells are more with Abemaciclib. They are more pronounced. Again, this is a reflection of continuous dosing. Unless and until you give a continuous dose, you cannot induce senescence and apoptosis in cancer cells. So, among the three drugs, the drug that causes senescence and apoptosis is Abemaciclib, which is there in this particular table or the graph, right? Now comes to what is the rationale for giving 2 years of adjuvant CDK4/6 inhibitor. This is the graph that says that the peak happens around 1.5 years and then comes down by 2 years. So this is sort of a primary endocrine resistant relapse that you're going to see. And therefore, if you want to prevent these aggressive relapse, giving a CDK4/6 inhibitor for 2 years is an optimal duration. We do see late relapses up to 20 years. We can't keep giving these drugs for so long. You need to give for a brief duration when the peak of relapse happens. After the peak has subsided, you're supposed to stop it because it causes toxicity if you give beyond it. And we need to look for what is known as a carryover effect. So giving beyond 2 years as per this is not a great idea because the peak has already subsided. Right. So now we have two trials, that is MonarchE and we have NATALEE for adjuvant CDK4/6 inhibition. So the general impression that we have with MonarchE is MonarchE includes that 15 to 20% populations who have a high risk of relapse, like more than 3 nodes or any node positivity with a tumor size more than 5 or a grade 3 disease, which is a very high risk of relapse. And NATALEE usually uses an impression that it includes node negative, lesser stage patients. Therefore, we do not expect much IDFS benefit with NATALEE. But if you actually compare the inclusion of patients of MonarchE and NATALEE, what you have to see is the N0 disease in NATALEE is just 15%, right? 85% of patients were node positive disease. At least roughly, unless and until you have the MonarchE subset picking up from the NATALEE, we do not know the exact percentage, but roughly what I can say is NATALEE is not including very low risk or early stage patients so that the benefit may be less. It is including node positive patients in nearly 85%. So I do not see the inclusion criteria of NATALEE and MonarchE as completely different. I see these trials as almost similar in terms of the inclusion criteria. 85% patients are node positive. So for me, if you look into the patient population, MonarchE equals NATALEE. Both are addressing a high risk patients. Right. Now let us see what is the IDFS benefit with MonarchE and NATALEE. So we have the 5-year data of uh, MonarchE and we have a 4-year data of NATALEE. Let us see what it is. So the difference is 7.6 at 5 years for MonarchE and at 4 years it is 6% and it is 4.8. It is 6 versus 4.9. And if I have to have a realistic picturization of what is the difference between the curves, and there we go. So in the MonarchE curve, you can see the rabbit easily passing between the Abema and the control arm or the endocrine therapy only arm. Whereas if you look into the right side of the graph, that is the NATALEE graph, the ribociclib arm is actually crossing door. So therefore, the ant is having difficulty in entering. So and also the gap between the two lines is so narrow that the ant is struggling to enter. So this is a picturization of how narrow the difference in NATALEE is. Whereas in MonarchE, you have a reasonable spacing for a rabbit to enter, whereas for NATALEE, even an ant is struggling to enter. Right. So the hazard ratios are, of course, better with MonarchE than with NATALEE, and I will show you the subsequent slides. So this is what you have. At 4 years, let us take the node positive patients only, which had 85% of NATALEE patients. The IDFS is 5%, and for MonarchE, it is 6%. So in spite of having similar population, the IDFS is better with MonarchE. I'm comparing node positive versus node positive. And the hazard ratio is better for MonarchE than with NATALEE. Right. So this is a sort of a head-to-head comparison of node positive versus in patients of NATALEE and MonarchE. Right. Then coming on to IDFS of MonarchE and NATALEE, very important is IDFS has 6 components. In that, distant disease-free survival or distant relapse-free survival. For NATALEE, we call it as DDFS. For MonarchE, it is DRFS, but roughly, I mean, they're actually similar. It is a distant relapse-free survival. So, of all the IDFS 6 components, if the DDFS and DRFS contribution is high, it is likely to translate to overall survival benefit. If I have a local recurrence or a regional recurrence, it can be easily salvaged by local therapies. Or a second primary tumor, they can be easily salvaged. Whereas if I have a distant relapse, they are the ones that are likely to create mortality, cause mortality. So if I can reduce the DDFS or the DRFS, that is the real efficacy of the drug. So just look into the 4 graphs. The top left is the IDFS of NATALEE, and the top right is the DDFS of NATALEE. IDFS of NATALEE is still the ant can pass through, whereas DDFS is so narrow that the author has also not named the delta between the two lines. Whereas for IDFS, he has labeled the difference, whereas for DDFS, uh, there is no labeling of the delta. So it is so narrow that even an ant cannot pass through the DDFS. So DDFS contribution to IDFS and NATALEE is very less. Whereas for the lower two curves, that is the MonarchE curves, IDFS and DDFS are almost similar, right? It is like 7.6 and 6.7 at 5 years. So, and the hazard ratio is impressive for both. So just to put it in a perspective, so these are some comments in the Twitter saying that the more I see the NATALEE curves, I feel this is not what I need. And uh, probably we need much better separation. And you need to it's difficult to put a laser between the two curves, especially the DDFS is concerned. You need magnifying glasses to look at overall survival. Right. So very important is what is the contribution of DRFS in the IDFS is nearly 88% for MonarchE and only 66% for NATALEE. So if the contribution of DDFS is high, that means probably it will translate to overall survival benefit. Fair enough. IDFS 6 versus 5 in the node positive patients, and DRFS is significantly less in the NATALEE. Right. So these are some criticism of course, it has happened both in MonarchE and NATALEE. This is called informative censoring, where you randomized the patients. It was not a placebo-controlled study. After randomization, these patients who could afford a CDK4 inhibitor, they opted out of the trial because they got into the control arm, and then they took the medication on their own. So this is something called like dropout after randomization. This is seen in both trials, but this is what you need to note. If this was also taken away, probably the IDFS difference wouldn't have been that much. That is the criticism of this NATALEE. Right. So now there is a rationale for the MonarchE inclusion criteria, like an N2 disease or a like 4 or more nodes, or 1 to 3 with a tumor size of more than 5 or a grade 3. This is based on this particular graph. So if you had a grade 3 disease or the MonarchE inclusion criteria, the survival is as bad as a triple negative breast cancer, right? So therefore, to improve on this, you need an adjuvant CDK4 inhibitor. This is the rationale for the MonarchE inclusion criteria, right? Now let us look into the forest plot, the subgroup analysis of the NATALEE. Let us focus on the N0, 15% patients, small number, but what you have to note is it is crossing the unity. The hazard ratio is modest, 0.82, and the IDFS is crossing the unity. It is crossing 1. It is 1.4, right? So this is a problem. You're probably harming patients. Probably they do not have a very high risk of relapse, and you are giving an extra treatment, and the confidence interval is crossing the unity. So therefore, that's an issue. So the IDF is crossing the unity, and it is probably harming these patients. Similar thing is also uh, uh, seen with N0 disease, and if there was no previous chemotherapy given. So this is that you need to remember. So we should be very judicious in giving adjuvant CDK4 inhibitors, especially in an N0 disease. Even here, we understand that the number of patients were less, but still crossing unity is probably not desirable, right? And you can see the crossing over happening more significantly. In the N0, there is crossover, whereas in N1 to N3, there is no crossover. So therefore, we should be very careful before we give adjuvant CDK4 inhibitor in the N0 disease. Right. So I'm just trying to say that even the MonarchE forest plot, if you see those patients who have a borderline performance status or who have a grade 1 disease, uh, or elderly patients who have issue with tolerance, in them the benefit is not that great. So we should be careful even in these patients, right? So now coming on to the exact number needed to treat one relapse is 13 for Abemaciclib and 33 for RIbociclib based on the recent data. However, we have to see the longer follow-up and see what happens to this difference. But at present, this is the difference. So the productivity, the yield of uh, the benefit of Abemaciclib is higher. So I have to treat 33 patients to prevent one recurrence for Ribo and 13 patients to prevent one recurrence in Abema. Right. So this is what I am speaking about. If you look into the follow-up is after stopping the drug, how much follow-up do I have? This is important because there's no point that I gave a drug for 2 years and then it immediately relapsed. So, but what you can see in MonarchE, let us see what is this carryover effect. So, for MonarchE, we are giving Abemaciclib for 2 years and then we are stopping and we are continuing only endocrine therapy. So, as per the data right now, we have all of them have completed 2 years and 80% have completed plus 2 years follow-up after stopping Abema. So, we have a very long follow-up. I mean, not very long, like longer than NATALEE. The IDFS and DRFS are showing impressive incremental improvement. You can see the IDFS improvement like 7.2 to 5.1, I mean the 3.2 to 5.1 to 6 to 7.9. So there is an incremental improvement in the IDFS benefit that you are seeing. This is what is called as the carryover effect. You have stopped the drug, and after stopping beyond 2 years, the curves are continuing to separate. This is what is known as the carryover effect. Now coming on to NATALEE. NATALEE is it's 3 long years before they stop. You have to take adjuvant ribo. All are off ribo right now. And 6 out of 10 only could complete 3 years of ribociclib. Hardly 0.4% have completed 2 years follow-up after stopping ribo. So therefore, the follow-up is shorter to see a carryover effect. IDFS and DRFS are showing increment, but it is modest only. So MonarchE, you can see an eagle without the wings being moved, it is just flowing. So this is called as a carryover effect, whereas with NATALEE, it is still many of them, I mean, have not crossed a long time after stopping ribociclib. Right. Now coming on to endocrine partner. So in NATALEE, the endocrine partner was a non-steroidal aromatase inhibitor with ovarian suppression if it's premenopausal. Because there is an issue with QT prolongation if I give tamoxifen and ribociclib together, therefore tamoxifen was not given. With MonarchE, 30% patients received tamoxifen as an adjuvant endocrine partner, and NSAI was allowed in rest 70%. So what you need to remember is, if you look into the demographics of the NATALEE, the previous endocrine therapy was anti-estrogen, that is tamoxifen, in nearly 13% patients, right? So, but these 13% patients were deemed only tamoxifen by the treating physician, that they do not need ovarian suppression, they do not need aromatase inhibitor. Just tamoxifen was sufficient because probably they were N0 or they were early stage. So, deliberately giving AI and OFS for these patients who had a lower risk of relapse, or for these patients who would have continued on tamoxifen, means I am giving more toxicity. So there is no freedom for choosing tamoxifen if I am giving ribociclib. Whereas for MonarchE, I can choose both tamoxifen and the aromatase inhibitor. So this is the advantage of using a MonarchE regimen than a NATALEE, where I have the freedom of choosing my endocrine partner. Of course, we need to be cognizant about the thromboembolic events if I'm using tamoxifen with abemaciclib. Right. So this is a simple inclusion criteria of MonarchE. So MonarchE is lymph node positive only, right? Whereas NATALEE had both lymph node positive and negative, but it was only 15% patients which were negative. So grade 3, uh, if it was a node negative disease, you could have had like T2 disease, but it should be grade 3 or grade 2 with all these high GEP, high recurrence score, or a more higher Ki67. And let us see what is the predictive impact of recurrence score, gene expression profiling, and Ki67 in the abemaciclib trial. So the MonarchE have went on to report the subgroup analysis of the intrinsic type, and you can see that irrespective of the intrinsic type of breast cancer, the benefit with abemaciclib was sustained. So therefore, these gene expression profiles are not predictive, but they may be prognostic. Similarly, the biomarker analysis, what we did, this is the oncotype DX based analysis. So the benefit was there irrespective of the recurrence score. Right? So the IDFS benefit persisted irrespective of the recurrence score. So therefore, again, it is prognostic and predictive of chemo, but not of giving the adjuvant CDK4/6 inhibitor. And then more, if you look into the genomics, like the BRCA germline BRCA mutant patients also benefited by adjuvant CDK4/6 inhibitor, and the Ki67, after all, looking into the data, again, what we understand is Ki67 is prognostic but not predictive. There is benefit with abemaciclib irrespective of Ki67. Right. Now let's go further. Looking at the side effect profile of MonarchE and NATALEE. So dose reduction, already you have a reduced dose with NATALEE, therefore the dose reduction is 22%, and dose discontinuation is 18% for MonarchE and 20% for NATALEE. So remember, if you could reduce the dose, if you could give abemaciclib in a reduced dose, the dose discontinuation rates were only 8%. But if you had to stop once for all, then it is 18%. So looks like ribociclib has a higher dose discontinuation rates due to toxicity. Then coming on to the type of adverse events that we have with abemaciclib, diarrhea, which can be easily managed. It's conservatively managed, and it's mainly of lower grades, and a rare venous thromboembolism. Whereas with NATALEE, it's side effects affecting vital organs like liver dysfunction, QT prolongation, neutropenia, which are more concerning. So then coming on to deaths, of course, we see even in the MonarchE trial also, but yes, there are significantly higher deaths in the ribociclib arm than in the aromatase inhibitor arm. And these are some critiques about the medical writers were used to write the NATALEE, but that is not mentioned in MonarchE. And then these are some recent guidelines after the ESMO is out. The paper that this is the ASCO guideline rapid recommendation update. And what they have clearly mentioned is the strength of recommendation is strong and the evidence quality is high for MonarchE, whereas for NATALEE, the evidence quality is high, but the strength of recommendation is conditional, that you would see in the next slide. And ISMPO also recommends abemaciclib for 2 years when they fit into the inclusion criteria of MonarchE. So how should clinicians select between Abema and Ribo when recommending these? So we favor Abema over Ribo. So this is clear message based on the ASCO guidelines rapid update. So this is the strength of recommendation I was saying. Its evidence quality is high for both, whereas the strength of recommendation is strong for Abema and it is conditional for ribociclib. So this is some surveys that we have on Twitter by Dr. Amol, and you can see 45%. I mean, when what will you use for those patients who are eligible for both? Like you had a MonarchE inclusion criteria, would you use Abema or Ribo? And you can see 45% voted for Abemaciclib for 2 years. So to conclude, continuous dosing matters with CDK4 inhibitors. Abemaciclib causes maximum senescence and apoptosis. 2 years is the ideal duration of CDK4 inhibition. NATALEE patients are not that different than MonarchE patients. It is almost 80 to 85% similar. MonarchE has better IDFS and a far better DRFS. DRFS is very important. It's far better. The carryover effect is more prominent with MonarchE because of longer follow-up and early stoppage, like 2 years it was stopped. You need to be judicious in selecting patients with high risk of recurrence, or else you may harm them. Ki-67 gene expression profiling and recurrence score are prognostic, but they are not predictive of CDK4/6 agents. Having tamoxifen as an endocrine partner is important. All guidelines recommend Abema over ribociclib. Right. So just a comment, just picking out the shortcomings of NATALEE. It involved majority of high-risk patients, 85%, and a very small percentage of node-negative patients, 15%. So this overall gives you an impression that NATALEE includes a lot of low-risk patients, but it is not so. It uses a lower drug dose of 400 milligram, but exactly all the registration trials are with 600 milligrams, and it is giving beyond the required period over a longer period. It is resulting in modest efficacy, but it aims to suggest benefits for all risk categories. Right. So what is my take? So it is often easier to criticize a study than to conduct one. Conducting a study requires significant effort and dedication. In my practice, I believe that both drugs have been life-saving and we should offer these drugs judiciously to eligible patients. Thank you for your patient hearing.